All right, Amy, I think we're ready to get started.
Okay, should I do the pre stuff or just go ahead?
You can just go ahead. We're rolling.
All righty. Good morning. I'm Amy Rowling McGee, the president of the Health Policy Institute of Ohio. And thank you for joining our online forum focused on innovations in access to care. Today, we're going to be joined by two in-state experts who are going to share their insights related to access to behavioral health care services in particular. The mission of Hpio is to provide the independent and nonpartisan analysis needed to create evidence-informed state health policy. I'd like to start by thanking our core funders whose steadfast investment in our work enables and supports us in providing this analysis. I also want to thank our 2021 Forum Series sponsors for their generous support of our online forum series. We encourage you to tweet throughout today's program and use the hashtag HPIO Forum. If you have questions for any of the presenters, please go ahead and type them in the question box, and we will pause periodically to ask those questions of the presenters. HPIO's most recent health value dashboard showed a number of challenges facing the state of Ohio in terms of health and health value. However, access to care was shown to be a relative strength here in our state. We know, though, that even though we've made a lot of progress here in terms of policies that support access to care, that access to high quality prevention and treatment services that are specifically focused on mental health and substance use disorders are still in need of improvement. So today what we're going to do is hear from two experts here in Ohio who've been working to improve and to analyze where Ohio stands relative to behavioral health access in our state. The onset of the COVID-19 pandemic has particularly changed how people access healthcare services. We've seen a lot of expansion and utilization of telehealth to address a wide array of health and mental health issues and other innovative services to support those in recovery from substance abuse. Today, our speakers are going to talk in more depth about strategies to increase access to quality behavioral health services for children, in particular those children facing adversity and trauma, and the importance of public funding for services and programs that promote mental health and prevent substance use disorders. Today's presentation slides and other related resources will be available and probably already are available on the HPIO website and can be found by clicking the Events tab. As I mentioned, our first speaker is going to focus on increasing access for care or access to care for children facing adversity and trauma. We're joined by Dr. Tracy Naheda, who is the Executive Director of the Children's Defense Fund of Ohio. CDF Ohio is a nonprofit child advocacy organization that has worked relentlessly for more than 40 years to ensure a level playing field for all Ohio children. CDF Ohio champions policies and programs that lift children out of poverty, protect them from abuse and neglect, and ensure their access to health care, quality education, and a moral and spiritual foundation. Good morning, Tracy.
Good morning.
Well, thank you so much for joining us.
Thank you. And thank you to HPIO for hosting this conversation.
All right, well, we'll let you take it away.
Okay. As Amy said, my name is Tracy Nahara, and I'm with Children's Defense Fund of Ohio. And I just want to take a moment to recognize the outstanding work of HPIO, especially their series around adverse childhood experiences. I think that it's significantly important for us to make sure that we're continuously building awareness of ACEs and what they are and how they present and the different things that, us as, advocates and also our policymakers at local and state and federal level, what they can do to, prevent and address them. Because what we do know is that, and of course, I'm going to be giving a little bit of a shout out here for HPIO. What we do know is that, nearly 2/3 of Ohio adults, about 61% in 2015, reported exposure to ACEs. And we do know that in the state of Ohio, Ohio as a state, that we are one of the states with the highest rates of children under the age of 18 experiencing 3 or more ACEs. So, that what that tells us is that, there's a lot that we need to be doing to support our kids and, how they're experiencing life. And also there's a lot of opportunity here to invest in interventions and support to, mitigate the later effects of ACEs. And so that brings me into what I'm going to be talking to you all about this morning. And that is a report on children's behavioral health that Children's Defense Fund has co-authored with the Mental Health and Addiction Advocacy Coalition. And I'm going to try to get some control of the slides here. Here we go. All right. So earlier this year, we published a report called Mind the Gap, Creating a Robust Continuum of Behavioral Health Care for Young Ohioans. And one of the things that really led us, for the impetus for doing this, is, acknowledgement of the high percentage of ACEs that exist right now in our child and adult population. And also, us asking continuously of ourselves and others, our colleagues, as these ACEs aren't treated and as they present in different behavioral health concerns, what kind of services and what kind of support are we providing to those children, to those adolescents, to those emerging adults who are then, themselves becoming parents? And the question and how it's answered, is different depending on where you are in the state of Ohio. And so this Mind the Gap, Creating a Robust Continuum of Behavioral Health Care for Ohioans, what it does, it seeks to begin to answer, some of these questions, or at least more fully delve into some of the questions, right, and recommendations. So what we've done is created a detailed, systematic look at overlapping systems and unmet needs that impact behavioral health for young Ohioans. And actually, we also propose a continuum of care that identifies the types of behavioral health services that are available at each age and stage of development. And we looked at young Ohioans as being from prenatal through age 26, and also included their caregivers, whether that be their foster parents, their birth parents, grandparents who are caring for them, because as we know, families look very different, today than maybe what was reported 20 or 30 years ago. And we want to be inclusive of who's caring for those children. And then we also looked at individual county profiles that include results from a survey of Ohio Adams boards on local availability of services to children and to their families, as well as data from the Ohio Department of Medicaid on behavioral health conditions and utilization of services. Now, we looked at Department of Medicaid data primarily because, that is publicly available information, and it was a bit more difficult to actually access information with private insurers. So we chose to use that more as a proxy of the state conditions. So in terms of behavioral health disorder prevalence, these are facts that I know that all of us are aware of. That is, not new to us. We've seen in newspaper articles, before and especially during the pandemic, about the cases of mental illness and behavioral health challenges of children, and how we're seeing more and more severe, challenges in younger children. And here's just a couple of statistics. So globally, about 50% of all lifetime cases of mental illness begin by the age of 14. Nationally, higher percentages of children between ages of 12 and 17 had a drug use disorder in the past year. Nationally, about half to 3/4 of our youth involved in the juvenile justice system met a criteria for mental health disorder. And at least 40 to 80% of those youth incarcerated have at least one diagnosable mental health disorder. And then now we look at Ohio, our own state, about 500,000, a little over 500,000 children of youth ages 8 to 25 have a mental illness and or substance use disorder. Of course, we've also seen very, very troubling reports of the teen suicide spikes over the last 4 years. And also about more than half of children expressing or experiencing major depression who did not receive mental health services, with only 1/3 of them receiving consistent treatment. And one of the things that we try to do, and I'm presenting all that data as kind of the why. Why do we feel that, and why do we know that behavioral health is so important that we need to focus on it? So now let's look at some overlapping systems. Ohio, we have, I would say that we have a rich array of programs of, societal supports, family supports, whether they be child care centers, schools, our healthcare providers, our courts. There's so many different points of entry for youth and for families, to have some kind of either interactions where perhaps a behavioral health concern could be identified, diagnosed, addressed, referred. There's a lot of different opportunities here. And what we believe is that in a well-functioning system, each entry point available or interacting with our youth and our families should be equipped to determine either appropriate interventions or diagnoses or referrals. And, here's just a list of, the different systems that we have in place, that have been identified and have been shown in a variety of ways, whether it be, through the types of services they're providing or the type of behavioral health, mental health providers that are working within their system, or even the requirements, for doing any type of intervention or just checklisting, what kind of behaviors are being expressed, in that youth or in that family at the time of intake or in the time of care. Another thing that I think is also important is recognizing, the racial equity impacts of 2020 and even previously, right? So there's a lot of global and national events, obviously, that have had an impact on our children's behavioral health in the past couple of years. Just with the pandemic in and of itself, and this is not a surprise. I know I'm not sharing, groundbreaking information here. We've seen, the articles, we've seen the reports about the rises in, stress and anxiety and depression. And, that's not just for the child themselves, but also for the whole family, right? And when the parents or the caregiver is experiencing these stressors, oftentimes it could lead to, those feelings being also translated and experienced by the child or the youth living in that home. And we can't underscore the impact, that the turmoil, right, around racism and police brutality after the deaths of Breonna Taylor, George Floyd, Walter Wireless, and many others, how that has had a negative mental health impact on youth, especially those who are, are Black and Brown, Indigenous, are people of color. And also, the other thing is around this pandemic that we're experiencing, just especially in the depths of the pandemic, the shortages or the increase, in the number of families who have experienced loss in terms of financial stability, loss in terms of family members, and what kind of impact, the isolation, the fiscal and economic stresses, that has on, children. And here's some data on the US Census Bureau's Household Pulse Survey, just, describing what that looks like. About 1/5 of those reporting had said that they had felt down, depressed, or hopeless more than half the previous week. And this was from a pulse survey from last year. Another thing that also we want to recognize is that, just in April of 2020, the proportion of children's mental health related ED visits among all pediatric emergency department visits increased and remained elevated through October of 2020 compared with 2019. So just really showing how the events, whether they be public health or racial equity or the combination of the two, have also had a significant impact on our children. So what we're talking about in terms of a continuum of care is that, for adults, there is a generally accepted unified continuum of care covering all aspects of behavioral health. And many times what we found in literature and what we found in conversations is that continuum of care for children, it varies. And so one of the things that we're putting forward in this report is that we should have a unified, and generally accepted and adopted continuum of care for children. And it should be used to develop state and local planning, to identify gaps in our behavioral healthcare system, allocating resources, and also for making policy decisions. And here's just some information about how we developed it, and also what we're considering as part of a continuum of care model. And for these purposes, we are proposing one for prenatal, maternal, up to age 26, along with caregivers. Because, children don't live in a bubble. They don't live, on their own. They're cared for by adults. And, adults are the gatekeepers in many ways, to getting access to behavioral health services. And there's a lot of barriers to that. We also, in this continuum of care framework, it includes about 11 domains spanning physical health, health promotion, prevention, treatment, and recovery support services. And then here in this green box, you can see we've identified those different domains. Within the report also, we also went through and created a glossary and a chart, and there's some visuals, and I can drop after my presentation a link to the report. It's about 300 pages, but most of those, I promise you, are county profiles. But to give you a visual idea of what a continuum of care can look like, and also when we're using certain terminology, what does that mean? Because I think often, we get bogged down in jargon, but we want to be very clear about, what we're referring to in it. And then also within the report, and I apologize for this being cut off, but we identified challenges to creating and accessing that continuum of care. So we identified several different challenges dealing with parity, right, funding, workforce, caregiver understanding and participation, race equity, data, and several other factors. So in terms of parity, I'm not going to read this slide, but basically making sure that there is insurance coverage for behavioral health disorders, and that it is no more restrictive than regular, health coverage for like physical conditions. So we want to make sure that we're treating behavioral health issues similarly when we're talking about insurance coverage and what will be covered by it and paid for. And here's just some information for you around the parity issue. In terms of funding, so we recognize that behavioral health services are supported through different and multiple sources, and which can also be health insurance plans is one of those. But we also recognize that there's areas of the continuum of care that we've identified within our framework that most insurance plans don't cover. Everything from prevention services or long-term recovery supports. We hear stories about, people having to pay in cash, right, for services because providers won't accept insurance. And that can be a real barrier to getting access. Just another note of the factors that influence, health, clinical care access, and quality contribute about 20% of the actual impact on overall health. So, this is really critical. So while social, economic, and physical environments make up 50% of what impacts health outcomes, we know that 20%, is through that clinical care and access. Now, another barrier that we've also seen is, and we've heard this repeatedly, is workforce. Our behavioral health workforce, is, we have a significant shortage throughout the state, especially depending on where you live. And that in of itself can present a significant barrier. So if you can imagine a child who, their caregivers identify they're having issues, they're having some behavioral health issues, they're, continuously withdrawing, they're isolating, maybe they're not eating, they're presenting all these different behavioral health issues, and they try to contact a provider, to maybe do some intervention or, try to do some diagnosis or figure out what's going on. We've heard stories, and I'm sure many of you have heard stories where there can be anywhere between a 6 to 12 month wait, to see someone, which, can be really frustrating, and also can be, the difference between whether or not those behavioral health, challenges become, more acute or, or what happens next. But again, the workforce challenges, they include everything from recruitment and retention issues, professional burnout, as a big reason for retention issues, the pay and compensation, and we're talking total compensation, is an issue. Maybe low reimbursement rates when it comes to Medicaid, or, insurance plans. And the need for quality mentoring and supervision, is also a challenge here. We also talk about the need for the workforce reflect in the community, right? We want to see someone who maybe has either empathy or experience, or we perceive as having more empathy and experience for our lived experiences when we're, divulging, significant challenges in our own health and are looking for help. And also the need for loan repayments and forgiveness. Education, obviously higher education is expensive. So we need to be able to provide those supports to get more people, more workforce into that pipeline. Caregiver understanding participation is also a big issue, in that, there could be stigma, issues of mental health literacy amongst the caregiver, how to recognize certain challenges. So there are a variety of barriers, where that gatekeeper of a parent might not be able to, or might not be willing to seek services for their child, that we also have to understand. Oh, excuse me. Racial equity. And I know that this is something that many of our health service providers are really digging into in terms of, cultural competency. addressing language barriers, making sure you have those medical translators, right? And not depending, and this does happen in some cases where someone who does not speak English as a first language might bring a younger relative to translate for them. And, and many times this is, not appropriate. And we really need to make sure that we have those medical translators to provide and to bridge that support for access. There's also could be a distrust in healthcare systems or lack of insurance or underinsurance. So all of these, right, can contribute to race equity or inequities in access or in services. And then also data. So I'm going to double down on the data piece. This is always a challenge because without good data, we don't know what our shortages are. We don't know what, our care profile within a certain community looks like. Now, and what we try to do with our report, and we've provided some county profiles, is using this continuum of care that we've defined to try to figure out with the counties, with our Adams boards, where do they perceive themselves in being able to provide services in the different areas of that continuum of care? Do shortages exist, right? Or do they have like robust systems in place already to address needs? And then we also provide information around, Medicaid reimbursements for behavioral health within those county profiles to give us an idea of, what are the defined needs, right? Demands, and then what based on the continuum of care actually exists. But I'll tell you this right now, one thing that we do know is that we need to have a better way of understanding what the behavioral health system looks like, and what additionally can be done to address some of those challenges that we spoke of before with workforce, with parity, race equity, et cetera. So here's a couple slides just on some of the Medicaid data that we looked at. So percentage of Medicaid recipients receiving any behavioral health services. So, we see that, and this is also based on 2019 data by age group. So we looked at it through, from these age perspectives. So if you'd be interested in looking at county profiles, it would have that breakdown. And we also looked at some Ohio MOS data as well. And, though they license providers, but they don't necessarily identify where they serve. However, I know that this information is being updated. It sounds like there's a mapping project that is a voluntary project, but one that will hopefully better identify where those services exist. So you can get a more 10,000 foot view, as well as a, kind of granular view on service providers. And then here's just a general look at our county profiles. And when you look at our data, when you look at what we have here, we're looking at state and county statistics around, the young Ohio population, those who are enrolled in Medicaid, et cetera. And also looking at the Medicaid profile. One of the interesting things also is we were able to see what kind of behavioral health conditions among young Ohioans, that are enrolled in Medicaid, what they're presenting. So you see that ADHD, for this particular example, right, that's the highest, the largest number that are being identified. And then you go down to the lowest, personality disorder, but you can see what we're talking about in terms of that. I believe that this is, a county profile or Adams board of Adams, Lawrence, Scioto County. So this is just an example of another piece, on the total operating budget, the number of contracted agencies, and, some other information that we were able to gather from the Adam H boards. And then also behavioral health measures by age group. So, this was a different way of us, breaking down the Medicaid spending on behavioral health per youth compared with averages for Ohio. So a couple key findings that we identified were, number one, Medicaid is a critical partner in driving policy change. Also a call out on Ohio Rise managed care plan to address the needs, the behavioral health needs for youth, for young Ohioans. One of the things that many of the ADAM-H boards that we surveyed through this work noted consistently was that they needed timely access to data. And that would be the most beneficial thing for their own operations and understanding their own local landscape of services. And also the availability of services for Ohioans, young Ohioans at each age and stage is very inconsistent throughout the state. So, you know, much like many other systems like education, child welfare, you know, the availability of services is really dependent on where you live. So in terms of the recommendations, again, here are the 7 that we called out within the report. And then some of the implications that, you know, for young Ohioans is that, you know, the access to quality services, ongoing treatments, et cetera, that these all increase the likelihood of positive life outcomes and benefits, all Ohioans, not just the individuals that are accessing the service and the family in that moment, but all Ohioans would benefit from this. When you think about, you know, children who are experiencing ACEs and their access to services to address the needs, maybe the behavioral health needs that are, you know, that present as a result of unaddressed trauma, you know, we can only, that child benefits from those services, but also the rest of us can only benefit from that youth, from that individual being able to thrive and flourish into adulthood, you know, ready to tackle the later stresses in their life as they become an adult and as a parent. So it's something that we can all benefit from. Also, more comprehensive and more equitable policies are needed to resolve these gaps in the continuum of care. And lastly, Ohio's workforce now and later will be impacted. So we have to give the supports now to young Ohioans so that they can, you know, be able to thrive, be able to successfully flourish into adulthood.
Great. Thank you. Thank you, Tracy. We do have a few questions. Before we get to the questions, though, I want to commend the Children's Defense Fund and the Mental Health and Addiction Advocacy Coalition for this robust report. One of the findings of our health value dashboard is that childhood adversity and trauma have long-term consequences, both in terms of equitable health outcomes and sustainable healthcare spending. We need more analysis like this and more action along the lines of what you've highlighted in your recommendations in order to more thoroughly and sufficiently address childhood adversity and trauma. I have a question in my mind, but I'm gonna get to other questions here first. So the first one is from Ree Malley, who's from Hpio as well. And she asked, what steps can Ohio take to overcome workforce and treatment challenges that specifically impact behavioral health care for Ohioans of color?
You know, that's a great question, because I think that, and we see this in many of our workforce challenges, whether it be in education, you know, and healthcare, behavioral healthcare, you know, the pipeline is not attracting, you know, practitioners, providers of color. And that is a challenge, especially when we have, you know, individuals who would maybe feel more comfortable, you know, speaking with someone who has a similar life experience, or maybe who has experience with other languages that can more easily or naturally, you know, communicate with individuals. So the workforce challenges, I mean, are many. Number one, I think having more awareness building around what behavioral health professions look like. I think having more opportunities for things like stackable certificates. So if you have maybe an associate's degree, that can then translate into a bachelor's degree in either social work or case management, or, you know, maybe addiction services of some sort. You know, I think that would be a great thing to be able to do. But also when you think about total compensation for individuals in this field, I mean, it's low, right? I mean, that's one of the main reasons why individuals, along with burnout, leave the profession. So I think being able to pay them properly or at market, and also, what are some things that we can do to mitigate burnouts? Is it lowering the case numbers, right? Or the number of people that you're treating at a time, or is it providing behavioral health, services to those individuals who are the direct providers, because, there's secondary trauma occurring as well.
Well, thank you for that response. We have another question. This is from Dawn Thomas. She comments that the county profiles are a great source of data and wondered if any of that data is available broken down by race and or ethnicity.
Yeah, so we attempted to break down some of that information by race and ethnicity. However, one of the challenges, and I think this is really common for any type of research, if you have a small percentage, you really don't want to report it. So, if you have in education, I know we used, if any school district had under 8 children, scoring at something or experiencing something, they would just not report it at all, because you don't want that to be identifiable to those children. So I think that was a challenge in some counties where you had really small percentages of maybe Black or brown children. But I think in the aggregate, I think that, as a state, we're more able to report that. So I think it really just depends on where we're at, and the N size for that. And that would be the population size. So obviously we would like more data. I think that's only is useful and able to extract insights from it for actionable steps. But we're trying, and that's something that we're continuously advocating for. I'm sure Hpio is, as well as many others.
Absolutely, we are, and we totally support your championing of good data, and especially good data that is broken down by race and ethnicity. I have one last question, and then we'll get to Helen. And you mentioned in one of your slides that there was a bill passed in Ohio in December of 2020 that aligned Ohio's parity law with the federal parity law. What impact do you hope or expect that will have?
Well, I think that we all hope, and I think that everyone that worked on that hoped that it would mean that more individuals would be able to use and access quality behavioral health services, and no longer fear, the fact that maybe there would be lower rate of pay for that services, putting more burden on the individual, and also for the providers being able to accept individuals, for those services. And I think that in theory, all of that works well when we have a robust workforce that's ready to accept those patients or accept those individuals into care, if that makes sense. And I feel like right now that's really the barrier here, the workforce.
Right. Well, thank you again for your presentation. I do see one more question just to pop into the chat. So if you wouldn't mind, Tracy, just taking a second to respond to that question. We're going to move on to Helen Jones Kelly for the next presentation. Helen is the Executive Director of the Alcohol, Drug Addiction, and Mental Health Services Board for Montgomery County. Adamus is responsible for the planning, funding, and monitoring of public mental health and addiction treatment services for individuals and families in that county. The board is one of 50 boards that coordinate the public behavioral health and addiction treatment and recovery system in Ohio. Thank you for joining us today, Helen.
It is my pleasure, and thank you so much both for inviting me to participate and for sponsoring this forum, because I think it's really important that we have opportunities to have just casual conversation around some of the issues that seem to plague our system and some of our recovery efforts after being in pandemic for such a long time. So thank you for this opportunity.
Well, you're welcome. We always enjoy hearing from you, and we asked you to do something kind of unique today. We wanted you to focus on access to prevention services, because we know that, of course, we need a robust treatment and recovery system here in our state, but we all, I think it's a goal commonly shared by those in the field, that we need to recognize the need to get to the problems before they get to the point where they need treatment, where we need more treatment. So we'd like for you to reflect on that, and to make sure, and also efforts to make sure that there's equitable access to prevention services here in our state and in your county. So with that, I will remove myself from the camera and let you take it away.
Thank you. And I really appreciate the opportunity to talk prevention because it's not typically something that we spend much time in. And I'm going to see if I'm going to make sure that I am controlling the screen, and I'll move from there. I did such a good job a little while ago. All right. So Alana, I may need to ask you to there. Thank you. Thank you. So as I'm talking about prevention today, I want to take us back just a few steps, because one of the things that seems to happen whenever the prevention conversation comes up, when we cut budgets, the first thing we do typically is cut prevention. It's as if it's not an important element of mental well-being. And unfortunately, for so many years, because we have cut it first from our budgets when we go through difficult times, we find ourselves continually trying to build a prevention system, both globally as well as at the local level. And so one of the things that's occurred in our community is a deliberate and intentional focus on prevention services. We see that as really the most important step for being able to truly integrate ourselves into healthcare. And we've talked for years about integration of behavioral health and physical health, and really where the rubber hits the road is with intentionality around prevention services. So instead of looking at it as kind of that low-hanging fruit to balance the budget, we look at it as one of the most important elements of building our budget, and we've pretty much flipped the budget on its head as a result of that. And there's a reason for that, because we spend a lot of time trying to treat the after effects of situations that occur in our system. So, thinking in terms of the proverbial situation where the baby is falling into the water, and we're all trying to grab to get the baby out. And one of our trainings or experiences with Racial Equity Institute is just the scenario that occurs with that. As an example, I'm trying to grab the baby out of the water, and the person standing next to me, I'm just going to pick on people because I'm seeing screens. Okay, so I'm telling Amy, take the baby and put a diaper on the baby. And then Tracy, take the baby from Amy, start warming the baby by putting a blanket on the baby. And then Alana, you take the baby from Tracy and you start feeding the baby. But by that time, I've had to turn my back and already grab another baby out. And we keep this assembly line thing going and going. And the problem is there aren't enough resources. There aren't enough blankets. There aren't enough situations where we can keep building this assembly line as for this individual baby and these individual babies, and keep building this thing out. We don't have time to get more blankets. We don't have time to get more diapers or to go grab more formula. And we don't have the thinking time that's necessary, because I've got to keep turning and pull the baby out. it doesn't give us the ability to take the time to build in the system of care that allows us to think about why in the world did the baby fall into the water in the first place? What's happening that's causing all of these babies to fall into the water? And that's where we decided to spend our time as a system of care in our community and building in the prevention resources. We have to go upstream if we're going to be able to make any difference for finding out the source of the babies falling into the water and figuring out what the solution is. How do we solve the problem in the first place? So in the spirit of going upstream and being able to stop pulling the babies out of the water, as I paraphrase Archbishop Desmond Tutu, we need to go upstream and find out why they're falling into the water in the first place. What's happening within our system of care, or just within our environment, that's making this a huge problem for us, and how do we address it before it becomes larger, and how do we get control of our resources? You know, we think of prevention as not being of value because you can't measure it, you can't ever determine if you're getting your money's worth. Well, the reality is, it's one of the few ways in which to get control over your resources and over the problem-solving processes. So we went upstream, and we've adopted a conversation in our community that is really built upon that upstream healthcare, and looking at ourselves again as part of the integration into the healthcare system, and using our desire for environmental well-being and the well-being of those who are dealing with other brain health issues like substance use disorder, and all of the other elements that play into community, including just that sense of safety, and putting a program into place that allows us moving upstream and identifying those factors that are impacting the system that then plagues our treatment and other supportive services. And so early on last year, Dr. Thea James, who is an MD with Boston University Hospital, created a definition for upstream care, upstream health care. And she describes it as an approach to care that examines and addresses root causes rather than addressing the symptoms. And in using that upstream approach, we can improve long-term outcomes, and ultimately, get this, prevention can decrease healthcare costs. That was a real awakening for us, and we began to examine how we could begin to take in some of this conversation and use it to impact our program planning and moving forward some of the services in our community that would make a difference. So one of the things that has been identified in this conversation is this list of upstream factors, and they're going to begin to bear some similarity to some of the other conversations that we've had over time. And you know, we can agree or disagree about the real value of a conversation around determinants of health, because that's really what the upstream factors begin to support. But there's evidence that these are factors that we need to be paying attention to as we talk about planning in the behavioral health system. It can't just be a very, very factual statement. It has to be connections to some of the other factors that begin to play a role in well-being of community. So we talked about, as an example, this list of factors that are part of the current conversation around upstream factors. When you're starting to look at things like income, you know, what's the person bringing in? How much are they bringing in? And Tracy alluded to this as she talks about even the salaries within our health system, our system of care, and how low they are. We know how it is for teachers and others, people who are taking on the job of supporting other humans when they're in crisis, and they tend to be at the lower rung of income for a very, very unique and complex service system. So how much is the person bringing in, just in general? And what's the level of financial stability for people? You know, when they show up in our system of care, what are their worries around if they're going to be able to pay the mortgage, if they're going to be able to even put food on the table? And you think about how we have created these opportunities for children to be fed in other places than home, because we know that in some cases they're not being fed well at home. And that, you know, leads right back to that conversation about financial stability and income and other factors that play. Upstream factors, what is the educational system doing to support and to improve the well-being of people and their mental well-being? It's not just the attainment, but it's the access to quality, especially the learning that we've had now in the light of the COVID pandemic and learning at home. You know, it took some school districts a much longer time just to be able to set up a process for being able to have virtual education occurring. And then after they figured out the process, they found out, well, they couldn't connect to broadband because there were no broadband services in certain rural and certain urban communities. So there was another problem that had to be addressed as part of this process. So it took time, and that took away time for educational attainment for the youngsters. So that plays a huge role in those upstream or challenging factors that people face. Housing stability, there's been a lot of conversation about that, as well as food access. We found that our food banks were overwhelmed during the pandemic as people were no longer employed consistently and then in need of those very basic services for groceries, for housing. Housing illuminated another issue. We talk about Black and Brown people and the high incidences of the COVID infections. Yet we also know that Black and Brown people more often are living in multi-family situations, in low-income housing. And in those situations where many may be employed, but may be employed in those jobs that are considered those frontline jobs, cleaning the hospital rooms where the COVID patients are, having to do the food processing, the grocery store jobs where folks are setting up the shelving each night. There are situations in which they're obviously, it's a, you know, as our kids would say, duh, obviously in situations that are going to lead to higher incidences of infection. That was really illuminated. Those are those upstream factors that might be preventable with some planning, or just being in unsafe and non-walkable communities, as people find themselves trying to find ways to transport, and maybe the bus system doesn't go where they live, or maybe it's an inconsistent schedule, or it's a very long wait for public transportation, or maybe the car just doesn't start today. And how do I get the 3 kids and myself out to the obligations that I have? It sounds a lot like this conversation we've had in behavioral health now for the last few years around social determinants of health. That connection, that very obvious connection between physical health care and behavioral health care has been truly illuminated during this pandemic period. And I don't have to go through all of these to make that connection for you. I think Tracy certainly made it very well as she was talking about ACEs, you know, and those childhood experiences and generational trauma that travels with us over the course of a lifetime without some intervention. I've already spoken to housing and other kinds of supports, social supports that has application in physical health in the same way it does in behavioral health. And what can we do better around prevention with that? I think one of the worst things that we did in the conversation around how to remain safe from COVID was telling people to socially distance, socially isolate, just the terminology, as opposed to physically distance, because social isolation takes on a whole different context, especially for people who may be experiencing some brain health challenges. And socially distancing for them could cut them off, cut a lot of us off from our own systems of support. It was just the language, but it cut us off from that sense of well-being that might have prevented some of the increases in areas like substance use disorders and some of the first instances of youngsters doing some of the experimental things in isolation that they might not have tried otherwise. Absolute connection now that we are very, very clear about with respect to health disparities in the physical health system and now the behavioral health system, which really have an opportunity to bring us together in ways that we might not have considered before. And we took this very seriously within our system and decided that we needed to start looking at prevention in a very different way than we have in the past. And so we did. We tripled the amount of budget that we're putting into our prevention services because we began to look at our checkbook. You know, they say if you look at my checkbook, you can determine what my real values are. And absolutely that was the case with us. We looked at where we were spending special grants or some of those special programs that were coming about, and especially during the pandemic when our traditional prevention providers were not able to go into the buildings to provide their school-based programming. Then we had to come up with some other ways in which to ensure that services were being provided to youngsters who might be at home or not available at school or not available in the typical ways that they were in the past. And so we found ways to build in additional programming that helped our school systems to still provide meals. There was food distribution, but there was limited resource for getting it out there. And we made the prevention services a part of that aspect by preparing boxes, activity boxes that were allowing programs to still be deployed to youngsters as part of the daily process of being in an educational environment, though that educational environment was not in the bricks and mortar establishment that they were used to. It was at home. So we're talking about meals that are being delivered along with activity boxes with prevention activities. We also deployed an app, Positively, that's available Android, iOS, wherever one gets their apps for their phones, and it is free. We piloted that with our local large urban school system. It was loaded into all the Chromebooks that went home with the youngsters, and it has brain games and it has activities around behavioral health and connections to physical health, so that youngsters could begin to learn to talk about and express how they were feeling and to know how to talk about resources in ways that they might not have had those discussions earlier with their parents and caregivers. But there was an even bigger piece. We looked at this whole sense of poverty, and we started looking at prevention services within the context of environmental services as well as universal services. And there is a difference. And I don't profess to be your prevention specialist, but I've learned enough, as we can do just simply by having some of these conversations, to understand the value of arming ourselves with conversations around how we go upstream and arming ourselves with opportunities to see where those dots connect that just uniquely and obviously take us upstream with the way in which we begin to look at how we adjust ourselves for better physical and brain health. So when we think about environmental services, which is where a lot of our prevention services are, And we talk about the policies and strategies that are looking at community well-being, and how some of these can be locally enacted. Then we're talking about where most of our prevention services are across the entire prevention system. We're talking about those factors that lead to certain behaviors and that require a community response. But when we step that up, when we step that conversation up, and we really begin to move into that universal conversation around what really changes the way that we are globally preventing some of those factors that rob us of our mental well-being, then we start talking that universal language and those broader messages that are targeting a lot of people, total communities, states, and being able to build in the alignment across our system of care that really reaches the kind of resolutions that we want to see. We found that we had been spending a lot of time in that world of environment, but in that space, we were also being rather traditional in the way that we were funding services. So for so many years, within our state, we have talked a lot about prevention services, but we've talked about it within the context of school-based services, having to be able to deploy those programs primarily within our schools. And we've left a lot of the other prevention services to our physical health system. So we've started blending the work that we're doing. We also have, for so many years, paid for these services in a way that kind of promoted that sense that we weren't measuring outcomes. We started looking at that as well. The way in which we tend to fund those services is we pay prevention providers a 1/12 allotment, or we paid, because we don't do that anymore. We were giving them 1/12 of whatever their grant was on a monthly basis. And we weren't really going out there and defining what it was that we were purchasing. What are the results we want to have as a result of giving you these dollars? So we flipped the script and we stopped paying on a 1/12 basis. We actually set productivity standards for our prevention system. And we have set it up in a way that is building and making that system even more sophisticated. So for example, we have a 50% productivity standard now as a requirement within our contracts with our prevention providers. We are purchasing results, specific results, as a result of their touching the community within their sphere of influence and service. We allow for them to bill us for half of that for building out their specific services, for being able to better learn, to become more exposed to some of those global upstream issues that are playing a huge role in constraining behavioral health, and then finding ways to provide alternative programs to better connect some of the dots around those services. So we totally changed the way we fund prevention so that at the end of a contract term, and we don't just wait till the end, we do it periodic through the contract tenure, we're measuring where we stand with what we agreed the provider would give us and what we agreed that we would pay for. So we make sure that we have a way to measure the outcomes that we set. We also looked at how we are able to move our processes along in building better private-public partnerships. So one of the things that is the program that I'm really proud to be able to share with you today as being a real example of how these measurements can occur. We created a conscious retailer program within our community. And this one is set up to address a variety of prevention elements. We looked at the zip codes within the community that had the highest incidences of smoking, especially vaping sales, teens, youngsters who were getting access to the products. And we began to build this program out. What we're doing is looking at the high rates of gambling, the high rates of alcohol and tobacco sales, as well as the ages at which youngsters begin to access these products. Many of you drive through neighborhoods where you see those convenience stores with the windows covered with signs, and these signs are incentives, enticements, if you will, for a lot of our young people. So we built a program that addresses it. While we were in the pandemic period where a lot of people couldn't go into schools, we had our prevention providers assist us both with the analysis as well as the deployment of this program by getting retailers to agree to do certain things, both to get the signs out of the window so that public safety gets addressed, police can see inside, see what's going on. You can see youngsters inside and see what kinds of products they are accessing. And you give the retailer a sense of pride in really helping to address some of those healthy outcomes that we're trying to achieve with young people. So often we make presumptions and we presume that our retailers are in it for the dollar more so than they are for the benefit to community. So our presumption is our retail system wants to be a partner in benefiting the community. And we set this up in a way that allowed our prevention providers who weren't in school-based programs because of isolation to be able to go into the retailers within 5 of our primary zip codes where we had this issue and these kinds of stores with signage, and talking with the retailers about ways in which we could work together in order to promote healthier lifestyles for young people. And we set up a recognition program that supports them with both recognition for being a partner with us, a business partner with us, as well as really giving them a good value, because with this program, with the materials that we're providing, the social media that we're providing, there are levels of recognition that allow them to get advertising for being a full partner. And I'm going to share just a couple of examples with you. So I get really excited about this piece of it. So the 4 levels of recognition are bronze, silver, gold, and platinum. Those are levels that they are able to achieve for their involvement with the program. And to give you an example, a retailer who signs on to this program at the bronze level, for example, would receive these benefits. They would agree that their signage in their window would not exceed 20% of the windows. And they would agree that they would be posting all of the necessary signs to ensure that they were complying with age requirements for purchasing certain products. And they have signage about gambling and the gambling helpline. And for that, they're doing procedures, and they have a written procedure that they've shared with us about how they're addressing issues around fake IDs. They have ID scanning processes in place. They're doing compliance checks. We give them then the opportunity to be part of a social media campaign where they're standing up as good community partners. We also, at the platinum level, for their signage, and these folks are agreeing that they're not going to put certain signs in their window, age-restricted signs. They're going to make sure that they're paying attention to point of sale advertising so that they don't have certain things within certain feet of the counter space, so that they're really paying attention. And they're making eye level shelving occur within their stores for advertising. And as a result of that, they're placing products in certain places that are not going to entice young people, and they're paying attention to what young people are doing in their stores, not to harass them, but just to be supportive. Because after a while, word of mouth works. You can't go in here and get somebody to buy a product for you, nor can you go in and buy the product. And they've taken certain products off the shelves. And for that, they've written up drug-free workplace policies, because we're working with another provider who's helping with drug-free workplace policy development and smoke-free workplace policy. So we're also getting the retailer to engage in programming. And with that, they get certain benefits. Some of the benefits are things like billboards. At that platinum level, we have billboards that identify who our platinum level conscious retailers are. We do social media around people who are being good partners in the community, around making sure that young people are safe from certain products. We talk about them in ways that help them with so it adds a value, an advertising value to their services, anywhere from $2,700 on average a year to almost $7,000 a year as part of this partnership program. It also brings our business community and our business sector into this work around prevention services. And let's face it, it kept our prevention providers actively involved through the pandemic period. So they weren't just sitting at home, they were finding alternative ways to practice good and powerful prevention services, which took our healthcare system upstream through the pandemic, and continues to be an important way in which we are managing some of our public and private partnerships with other partners that would not have typically been engaged with us at the behavioral health level. So it's also elevated the image of brain health and behavioral health as an important part of the conversation around workplace development. I know time is an issue here, so I'm just going to go to this last slide and just tell you what's the why. You know, when you're doing work, you have to always have a why. And our why is this. We believe we have a financial, because we're financial fiscal stewards of tax dollars. So we have a financial and a moral imperative to prioritize policies and funding that prevent or intervene in behaviors that would otherwise thwart overall community well-being. But we can't do it in a vacuum. It takes the community. This is that proverbial, it takes the village. And this is one of the ways in which we're using prevention, evidence-based prevention, to build a better village. I'll stop there for questions.
Wonderful. Thank you, Helen. And I so appreciate the example that you just shared related to your efforts on preventing addiction to nicotine. I want to share a data point here, and that is, according to our health value dashboard, the rate of children who live in a household with a person who smokes is 2.4 times worse for Black Ohioans. And we know that oftentimes the focus on marketing these products is very much directed towards Black Ohioans or Black people in general in our country. So appreciate this focus and the fact that you're addressing it as a part of the substance use disorder prevention strategy too. I'm wondering what the uptake has been in terms of the number of retailers who are voluntarily participating in this program.
We have 15 on the hook. And what was interesting, when our board of trustees received the presentation that this is something we wanted to do, we wanted to fund, and we had one board member say, that is never going to happen. Those folks aren't going to buy into this. We have 15 on the hook. So we just hired an FTE who is going to get all of these agreements finalized and moving. We have the materials, and our prevention providers did a fabulous job of doing the analysis and of engaging them in the conversation that made them say, yeah, I think I want to sign up for this. Certainly it's a benefit to have the advertising on one side, but they're not going to get it without producing results. Yeah.
That's great. And I see that a participant in the forum today just asked a question about where can you get more information about the retailer program, the administration of it, the cost, the levels of benefits that you just described. And then this person also asked, is this a program only in Montgomery County, or is it statewide? Is this a national best practice, or something that you developed yourself in Montgomery County?
It is in Montgomery County, but it's the result of some of our prevention team having gone to a national conference and hearing about a program elsewhere and coming back and saying, I think we can do this here. And our prevention coalition really bought into it. Currently, the budget for this program is really not extremely high. I'm blocking, and I knew it this morning. I'm blocking at the moment, but it's something like 127,000 and some change to do the program. And that's all the materials, because about 80,000 of that are materials and other things that we've developed for the program. And then of course, now we've got a full-time person who is going to be living, breathing it, and creating that coalition of retailers that will continue to build upon it.
Great. So I guess I have many questions for you, but I'll just focus on one, and that is just continuing on the discussion related to nicotine addiction. What are 1, 2, or 3 things that you think state policymakers could do or do more of to prevent nicotine addiction?
The biggest one that we face is vaping, teen vaping. And we know the physical impacts, the negative impacts of that, especially the earlier, the worse, because the average age now is 12 to 14 years of age. We even got some younger than that. Lungs aren't completely developed yet. The system, the body just isn't able, physiology isn't able to take that in. And we end up with youngsters on ventilators because their lung capacity simply isn't there to be able to manage bringing in. And I know they say, oh, it's safe. It's just, no, it's not. It's a very difficult issue to address for youngsters. Also, the issue around the vaping flavors, because that is set up specifically to entice young people. And we learned that early with cigarettes, when we used to have candy cigarettes available and kids would see parents and caregivers smoking, they would think that was really cool. And that enticed younger, that it was that cultivation of the younger population. Same thing now, cultivation of the younger population with vaping, which then leads to the desire for something more, which then takes them into ingesting tobacco and the rates of cigarette sales. We also have some targeted sales as we look at the community. There are festivals and there are activities that are really targeting Black males, and we see a very high incidence of lung cancer with Black men. And that's a very direct result of the specific targeting that occurs with smoking for Black men.
Okay, wonderful. Thank you. Thank you so much for sharing all of your insights. It was just notable that you increased your budget for prevention threefold, and your focus on paying for results is laudable. So thank you so much for joining us. We're going to close out today's session with a poll question. We'd just like to get your quick reflection on how you would rate the quality of today's webinar. If you could just take a quick second to give us your thoughts there. We do, of course, use the information we receive from our evaluation surveys and poll questions like this to always improve our future programming. We appreciate you sharing your thoughts there. We hope that you've come away We'll close the poll now, and we'll hope that you've come away with a few thoughts, either a few pieces of data to explore further, some policy recommendations, perhaps to champion or learn more about. We always put in a plug for getting involved in the policymaking process. Our elected officials and our appointed officials and their staff are there to serve us. They want to serve us. They want to hear from their constituents. So if you've heard some information today that either encouraging or troubling or best practices that you'd like to see more of here in our state, always weighing in with our policymakers is an important way to influence systems change and make a broader impact, even beyond what you're impacting on a day-to-day basis in your direct work. So please take a moment to consider some of the ways that you might be able to engage your state policymakers in conversations related to access, and in particular, access to high-quality mental health, substance use disorder treatment, and prevention services. I think that's all we have for today. You will receive a short survey after today's event. We would appreciate your sharing additional feedback that way. Again, the slides and additional resources from today's forum are available on our events page. Thank you for joining us. Thank you for continuing to follow our work and support our work. We did, I think Tracy mentioned that we recently came out with a publication related to adverse childhood experiences. We hope you've had a chance to take a look at that. If not, that's on our website. Again, thanks and have a great day.